Welcome everyone to this special webinar event, ILLUMISITE Fluoroscopic Navigation Platform as Technology to Aid in Therapy Delivery with Dr. Bryan Benn. We want to thank our 2023 sponsors, Medtronic, for sponsoring this webinar tonight and their continued support through the years. Before we begin, just a few reminders to anyone new to the SAB webinars. You all are currently in a listen-only mode and are muted. You may ask any questions that you have throughout the lecture by using your chat or question feature. It is located on your control panel and you simply can submit them. We will answer all of your questions at the end with Dr. Benn. At this time, I'll hand it off to Dr. Benn to get us started, and thank you so much for joining.
Okay, hopefully everybody should be able to see my screen in a moment here. Okay. So thanks for the introduction. Good evening, everybody. Thanks for joining all of us for the presentation tonight. And I will be speaking about ILLUMISITE as a fluoroscopic navigation platform to aid in technology, as a technology to aid in therapy delivery. So to start the conversation, I think it's always great to do some objectives. So we'll start by just reviewing what we'll be talking about in the upcoming slides. So the first thing we want to talk about is pulmonary nodules and how do we go and assess risk for them. Then we'll go over some of the background on fluoroscopic navigation, digital tomosynthesis, and then we'll review some clinical evidence publications for the ILLUMISITE system. And then finally, we'll talk about nodule localization and different approaches to help facilitate figuring out where our nodules are inside the lung parenchyma, excuse me, to help with the next steps in the process. So we'll first talk about pulmonary nodules. So obviously it's something that's very familiar to all of us, and we deal with it every day in our clinical practices. And we've realized over time that the number of incidentally found pulmonary nodules continues to increase. Prior to this paper by Dr. Gould et al. In 2015, it was thought that there was maybe about 150,000 nodules identified each year. Turns out that we were off by just a little bit. There was about 1.5 million based on kind of machine learning and looking at the Kaiser healthcare system, estimated about 1.5 million incidentally found pulmonary nodules. So about an order of magnitude of 10 more nodules than we expected, so quite a bit. So then the question is, once we see all these nodules, what do we do with them? So obviously, we're very fortunate that experts have sat down and said, give us some guidelines, give us some clinical evidence to help guide us in our assessment. So one of the things we start to do when we see a person for a consultation regarding a nodule is we start to think about the pretest probability of this being malignant. And there's two main ways that we do that. One is by just clinical intuition itself, and the other, of course, is by using prediction calculators. And we'll go through that in a little bit in a moment. Then, of course, if we say, well, we're not sure what this is, but we think biopsy or tissue diagnosis is indicated, then fortunately, bronchoscopy is recommended as a guideline first step for initial diagnostic tests for patients with a suspicious lung nodule. Unfortunately, we've shown over the years that adherence to guidelines varies quite dramatically. There's a lot of difference in where people live, where people practice, access to care, things of that nature, and of course, patient preference has to be taken into consideration as well. So let's talk about, estimating the probability of lung cancer when we see a lung nodule or cancer that could be metastatic to the lung. So as we all know, it's a very critical first step in the process by which we start to engage our patients in shared decision making. We know that how we assess risk also influences the next steps, the diagnostic and the therapeutic choices that are presented to the patient and ultimately decided upon by the patient, maybe the patient's family members being involved, and of course, us as physician stakeholders. And of course, our risk assessment also really helps us to interpret what the results are from our diagnostic tests. So in terms of risk assessment, as we mentioned, there's really two main ways to do this. One is clinical, and the other is to use calculators. The clinical really is breaking down patients into three main groups: our low risk, our intermediate risk, and our high risk. And I think we're all pretty familiar with this. We look at things like smoking history, occupational environmental exposures, prior malignancy history, the size of the lesions, what it looks like on the CT, where it's located. And you can see that there's a pretty good sense for when something's low risk, something high risk, but there's a really wide range for what may be an intermediate risk, kind of a mixture of those high and low risk features, excuse me. And then of course there's calculators that are validated to help, but nothing is really 100% accurate in terms of predicting malignancy itself. So when we see something that's low risk, as we're all very familiar with from the Fleischner Society, for solid nodules, we've got really well-established criteria, whether it's one nodule, whether it's multiple, what it's looking like based on size and other characteristics of the patient, and how we define them as high risk and low risk. And similar criteria fortunately exist for subsolid or ground glass nodules. And again, whether or not it's part solid, it's mixed density, or it's purely ground glass if there's one or if there's more. So there's a lot of help for us when we see patients with these type of low risk scenarios. Similarly, for a high risk individual, it's pretty straightforward in terms of recommendations. We either try to treat the patient with a surgical resection or radiation treatment, or we perform a biopsy to confirm the diagnosis and stage. So again, low risk and high risk patients, kind of straightforward, we have a good plan. But the intermediate risk patients are really challenging because there's a lot of different options. You could pursue surgery, you could get a PET scan, you could repeat the imaging, or you could move forward with a non-surgical biopsy, such as bronchoscopy or a CT-guided or percutaneous biopsy. So when we look at bronchoscopic biopsies, evidence has shown us over the years, when we look at both meta-analyses and registry studies, that fortunately it's a low-risk procedure in general. Pretty low risk of complication, pneumothorax or pulmonary hemorrhage. And we've shown that when you add a type of guidance, whether it's any modality or combination of multiple modalities, in general, you're going to have higher sensitivity compared to just your traditional conventional bronchoscopy. And when we look at the Navigate study, which was a multi-center international study looking at the diagnostic yield and sensitivity of patients at 1 year and also at 2 years in follow-up, the sensitivity and diagnostic yield were in that kind of low 70-ish range, so kind of similar to prior meta-analyses and registry studies. The challenge, of course, is that CT-guided biopsy, diagnostic yield and sensitivity, about 90% or so. So we've got a lot of distance to make up. And so when you think about trying to make up the distance between these two modalities, one of the questions is, well, what's the limitation? And so in terms of one of the biggest limitations of bronchoscopic biopsies, it's really our inability to find the lesion. And there's two things that kind of impact that. One is the concept of CT to body divergence, which we're going to explore more on the following slides. Just the idea that we don't really know where the lesion is in real time in the person compared to where the lesion is supposed to be located based on the CT scan. The other big challenge is, of course, it's a blind procedure. We don't really know what our biopsy tool is doing or how it's interacting with the lesion inside the person in real time. So when we think about the CT to biodivergence part, we have to think about how our navigation bronchoscopy platforms kind of founded. What's the rationale and information that we use to help build the structure and build the technology. And so they're all basically based on the idea of taking a patient's initial CT scan prior to the bronchoscopy and trying to overlay it or overlap it with the patient's body and central airway in real time. And this is done by the different proprietary algorithms that the different companies and technologies have. And we know that it's pretty good inside the central airway. And that's partially because there's not a lot of respiratory variation or motion inside the trachea, the mainstem bronchi, and even into the segmental bronchus, maybe a little bit further out. But CT to biodivergence occurs when there's a difference between where the CT scan says the lesion is and where the person's lesion is in real time. And we know this happens as we get further and further out into the periphery of the lung. More and more challenges where divergence occurs, the further away we get from the things we can see with our bronchoscope in the central airway. And we know that this really can impact how well and how technically successful our procedure goes. One of the big issues of CT to biodivergence is the way that the patient breathes during the scan versus the procedure. You can see that during the scan, the patient's breathing at total lung capacity. We ask the patient to just take a deep breath in, hold it for a few seconds, and then the scan's done. But during a procedure, the patient's having regular breathing that's set by the ventilator, or if the patient's breathing on their own during a moderate sedation or conscious sedation procedure, they're breathing at some type of tidal volume. So you can see on the other side of the screen here that there's a big difference between where the CT scan says the airway is and where the lesion is going through that airway or beyond that airway to where the patient's airway and lesion are in real time. So this is a great study done back in 2015, looking at the effect of respiratory motion on nodule location, looking at really what's the change in the anatomy based on that CT scan done prior to the procedure compared to what's going on really with the procedure in real time. So 85 lesions were looked at in 46 patients, and there was a significant difference between where we thought the patient's nodule was and where it actually wound up being. It's about 17.6 millimeters. And this was even more dramatic, as you can see there in the figure, in the lower lobes. Interestingly enough, though, the size of the lesion, the distance from the pleura, none of that really had an impact. So this was kind of just independent of size and location in terms of distance from the pleura. So just you had CT to biodivergence greater in the lower lobes than the other lobes, but it was still dramatic, almost 18 millimeters. So now that we've identified CT biodivergence as a big challenge, we have to think of a way to try to overcome it. And one of the ways that that's done with the ILLUMISITE system is this process called a local registration. So basically, once the lesion is located during the navigation phase of the procedure, you have the option to launch the local registration. And once you do that, you can then have the patient set up in the appropriate positioning, fluoroscoping brought in appropriately, and you start basically 25 degrees in the other direction. So if it's a right-sided lesion, you'd be at LAO 25, and then you would sweep around and do a 50-degree rotation over the area of lung parenchyma of interest and perform this over about 10 to 12 seconds after the patient's been apneic, provided the patient's under general anesthesia, and then capture that imaging, taking a stack of basically two-dimensional pictures where you can't see anything as shown here under the fluoroscopic view. And you're basically creating a movie or a 3D volume of the nodule location in real time, and also the relationship of the locatable guide and extended working channel to said nodule. This allows you then to help see where the lesion is in real time by basically subtracting out all the things that could be obscuring it, such as metal artifacts, EKG leads, parts of visceral organs, bone, things like that. So it allows you to say, this is where the lesion is in real time. So once you know where the lesion is in real time, then you can say, well, where's my nearest airway and where's my catheter and locatable guide that's going through that airway? Let's relocate that and let's realign that to the lesion. So once you've updated your navigation catheter as well, you can then adjust the position of the catheter in relationship to the lesion in real time that you've just identified during that fluoroscopic sweep. This can correct for up to 3 centimeters of CT to biodivergence, right around where you're aiming or localizing the lesion. So this is really important because if your average correction is about 17.6, this should be able to account for any CT biodivergence that's occurring. So with the ILLUMISITE platform, one of the other nice features that we've talked about as a way to overcome another obstacle is to start thinking about, well, how do I know if my biopsy tool is interacting with my lesion in an appropriate way? So the cardinal directions of the navigation platform are also integrated in the extended working channel. So when you remove the locatable guide, instead of seeing what we've seen previously of superdimension, which is kind of an error message saying, you're no longer in the sensing volume, the screen kind of goes static, you're now able to see the kind of magenta yellow catheter change into this blue catheter as shown here on the bottom. And this allows you to get this continuous guidance So you can see what the tip of the catheter is doing in relationship to the lesion. So that gives you real-time feedback. You can see how the biopsy tool and the lesion are interacting in real time. So in essence, the process is you see where you were when you perform your traditional navigation. You do the local registration to see where you are, and then you can manipulate with the continuous tip tracking to see where you need to go. And that can help overcome these two big obstacles of CT body divergence and this being a blind procedure. So now let's talk about some of the clinical data. So this is the first paper looking at FluoroNav, which was the precursor to ILLUMISITE. So this just had the local registration option without the continuous tip tracking. This was done by the Vanderbilt group. They looked at 101 nodules biopsied with just their traditional superdimension, and then 67 nodules biopsied with fluoroscopic navigation. So they noticed a pretty significant improvement in correcting this CT by divergence over 12 millimeters on average, and they showed a significant improvement when they added the fluoroscopic navigation and local registration on, 79% compared to 54%. And of course, their odds ratio improved when they looked at their analyses by using the fluoroscopic navigation. So a follow-up study by the same group, they looked at 363 nodules over the course of a year. Nodule size was shown here, a little bit less than 2 centimeters, 65% in the outer third, 24% bronchosine positive, so some more challenging, smaller peripheral bronchosine negative, 76%. And they had 82% lesional findings. And then using very strict criteria, as you can see here in the kind of flow chart on the slide, when they took in consideration, all nodules lost to follow-up as false negatives, their diagnostic yield was about 77%. When they added on ILLUMISITE, this is the first paper now looking at ILLUMISITE, they looked at the first 100 lesions that they did, same nodule size about 2.3 with a little over half being less than 2 centimeters, showed a kind of similar target correction of about 10.4 millimeters. And they had an overall diagnostic yield of 79% for all patients who underwent the ILLUMISITE procedure, so the fluoroscopic navigation plus the continuous tip tracking. And then for those patients who only went the ILLUMISITE procedure, meaning that they went forward with launching local registration and using the continuous tip tracking, in 83 out of the 100, the other 17 had a positive or concentric radial EBUS sign, so they were just biopsied and had something positive on rapid on-site evaluation, so they didn't need to undergo the full ILLUMISITE procedure. 83% of those patients or those nodules had a diagnostic yield with the ILLUMISITE platform. And as expected, using the ILLUMISITE platform and having a concentric radial probe EBUS sign were predictors of an improved diagnostic yield in terms of odds ratios, as shown there in the lower table. So a couple other studies that have come out. The second study looking at ILLUMISITE looked at 78 lesions in 72 patients. Range of nodules with about 69% being greater than in the 2 to 3 centimeter size. Had a similar average target correction, about 15.4 millimeters, and their overall diagnostic yield was about 87%. So, showing some improvement in these first two publications compared to your traditional kind of meta-analyses and registry studies and the Navigate study looking at superdimension. And this is a publication that we did while I was at Medical College of Wisconsin. Cameron is was one of our medical students. He's now a resident over at Mayo Clinic. So he was first author in this paper. And we really wanted to look at how do we do with, kind of your more challenging lesions, your smaller bronchosine negative lung nodules, focusing on that. So we looked at 159 nodules. And you can see that our average nodule size was a little bit over 2 in 2 dimensions and over 3 in the sagittal. And then we were trying to focus more on these 72 or 45% that were less than 2 centimeters in all dimension, and then the 66% that were bronchosine negative. So our overall diagnostic yield was 84% for all comers, all nodules, kind of similar to the 2 prior publications. But then we looked at again, the traditionally harder to biopsy ones, and we also saw that we had a pretty nice diagnostic yield of about 75% for those that were 2 centimeters or less in all dimensions, and then 79% for our bronchosine negative lesions. We also wanted to say, well, is there anything else that we could do to help improve our diagnostic yield beyond kind of our traditional biopsy tools? So for this publication, we took a look at kind of the characteristics of the nodules, as you can see here: solid, bronchocyte negative, less than 2 centimeters in all dimensions, and kind of grouped them out. And then we really wanted to look at what does the different biopsy tools kind of add. And you can see here that, kind of as expected, needle aspiration, transbronchial needle aspiration gave us the most informative kind of picture. It gave us the most number of individual diagnoses and a good number of unique diagnoses as well. So when we started to layer things on sequentially based on rapid on-site evaluation, we saw that if we did after needle aspiration, we did 4 set biopsies, we were able to gain another 4 diagnoses to bring up our diagnostic yield from 69% to about 80. But if we added on using a 1.1 millimeter outer diameter single-use cryoprobe with carbon dioxide as the cryogen for this part of the procedure, we were able to capture another 6 unique diagnoses, and that improved our final diagnostic yield to 93%. Now, granted, this is a very small publication. It's 45 nodules, but that being said, it shows that there may be a role for kind of combining modalities in a sequential way in order to help improve our diagnostic yield so that we can get closer to that CT-guided biopsy results of about 90%. Fortunately, with cryo biopsy being performed, we had no interventions that required anything being done for bleeding, and no pneumothoraces occurred as well. So it was also, fortunately, a safe procedure. So now that we've talked about some clinical evidence for using the ILLUMISITE system for diagnosing and biopsying lung nodules, it's important to start thinking about not only diagnosing them, but what about localizing them? It's a suspicious nodule. It's been followed up over years. It's slowly growing. Its malignancy until proven otherwise. Or there's a patient with concern for clear oligometastatic disease. So not everything requires a biopsy. Sometimes it requires maybe a localization procedure, either instead of a biopsy or in addition to a biopsy, in order to help facilitate the next steps. And like we talked about earlier, we know that we're finding more and more nodules, incidentally, but also for lung cancer screening. And then again, many of these nodules are going to fall into a category where we need something. But sometimes that something may not be a bronchoscopic biopsy. It may be a way to just say, we know this is concerning, we want to remove it or treat it. What's the way to do that with the most accurate and minimally invasive way of doing such a thing? And that's the idea that we can use our bronchoscopic modalities to localize the lesions to help facilitate the next treatment modality, which may be a lung-sparing surgery. So there's really 2 main localization techniques that we're going to talk about. The first one, as you can see here, is marking with stains and dyes. And these are some of the common ones that are used quite often, methylene blue, indigo carmine, and ICG. And it really depends on some of the logistics. Sometimes you're going to be able to do the surgery immediately after. It may be a single anesthetic event. Other times there may be a significant delay. It could be days or even up to weeks. And there's data out there, including the paper that I'm a co-author on, looking at using ICG-soaked fiducial coils to help facilitate a lung-sparing surgery up to even 14 days later. So it really depends on access, patient characteristics, availability of surgeon, a lot of different factors that may help dictate or infer some type of decision making in terms of the type of marker that may be used. If we look at a sub-study or subset of patients from Navigate, what was really interesting about this was there were only 24 lesions from 7 of the sites that underwent dye marking. Now, the median nodule size was small, but there was a decent range there. And significant, almost 96% were located in the peripheral lung third. Median time from the dye marking procedure to the resection was really, about 30 minutes, and nothing was longer than 24 hours here. So a couple of points to bring up here is that only 24 lesions were dye marked, and there were likely if we look at the literature, in more detail, many more that were eligible. So there's barriers to doing this procedure, to doing a marking procedure. And the other thing, of course, to mention is that because of the types of dyes that were used, you really had to get that dye evaluated from the thoracic surgery standpoint within about 24 hours before you were concerned that it would either dissipate and no longer be at the pleural surface, or it would spread so far and so wide that you wouldn't be able to really localize the lesion appropriately. Fortunately, when this was done, over 91% were adequate, meaning that you could see them clearly, as shown in the figure here on the bottom, for surgical resection. The other significant localization technique is using fiducial markers, whether they're placed in the lesion, around the lesion, in and around the lesion. And then this is a figure of the SuperLock nitinol coil fiducial marker, which is approved to be used for these procedures. And then there's a figure here from one of the first papers back in Chest in 2007, showing the fiducial markers that were placed to help facilitate SBRT, in the CT axial view, and then close up, and then of the lesions in three different dimensions. So lots of different fiducial markers exist, and then we've talked also that there's different characteristics of them depending on what type of localization procedure is going to occur, and when the surgical resection may occur, or if we're going forward with some type of radiation therapy in the near future. And again, looking at a subset of patients from Navigate, there were more fiducial markers placed. We had 258 patients from 21 centers, and about 2.2 fiducials were placed on average for each patient. And this is one of the challenging things about placing the markers, so subjective assessment. So 99.2% were subjectively placed appropriately, but of course, as I show you here, that may only be on a portable X-ray, while the patient is just waking up from anesthesia. There hasn't been any literature yet showing, looking at CT scans and how accurate we are based on just the CT scan as a follow-up. So it'd be something kind of interesting to study. But that being said, subjectively, we do a pretty job of placing them correctly. And then when we look on follow-up imaging in this particular group, it said, they were still in place. It didn't say necessarily that they're in the right place, but they're still in place, right? And then fortunately, as similar to the dye marking subset of patients in Navigate, very low pneumothorax rate, not a lot of issues with respiratory failure, not a lot of issues with bleeding. So very nice to know that it's a relatively safe procedure. What about if we look at some more meta-analyses? So this is looking at nodules that were marked with dye. 15 studies, 523 patients, and the success rate again was very high, 96% in the navigation group. Very low risk of pneumothorax, about 3%, and no issues with bleeding. So very safe and successful procedure for localization. This is a little bit of a different meta-analysis. This is comparing bronchoscopic marking compared to CT scan. And so this looked at 7 retrospective studies and looked at 353 nodules that underwent CT-guided localization, and then 244 that underwent bronchoscopic localization. So kind of a similar rate of success. And in this case, the duration of localization was comparable. So wasn't really a big difference in most of these things in terms of technical success and the time of localization, as you see in the table, the first 2 rows there. But where we start to get a difference here is in the safety aspect. The rate of pneumothorax and bleeding favored significantly bronchoscopy. Another interesting study that was done looking at nodule localization looked at time required for localization, and then not only the localization part, but then getting onto the resection. So this was a single center retrospective group analysis of 117 patients. 81 went navigation and 36 went for CT-guided localization. No differences in demographics or in nodule characteristics. And from a subjective standpoint, 100% successful in both in localizing the target. And then later on, when they said after you did the localization, well, maybe there'll be a difference because some patients underwent, maybe a smaller wedge resection versus others went for a more complicated lobectomy. But in terms of the type of surgery, no difference. Fortunately, also no complication related to the localization procedures, but where there was a significant difference was in what they call the downtime or the wait time from the localization procedure to the resection. And when they went from the CT scanner to surgery, it was about 189 minutes. But when they went from navigation bronchoscopy to surgery, it was only 27 minutes. So significant difference there. So when we sum up peripheral pulmonary lesion localization, I think the things I want to emphasize is that data has shown both from individual studies and from meta-analyses that it's a safe procedure. It's effective. We're able to do it pretty well subjectively, and if we try to start teasing out some objective metrics. And at least one study shows that it may reduce time to surgery compared to percutaneous marking. I think that's a big deal because the more time that patients are waiting, it's the more time that patients are waiting, and we want to move them through the day with efficiency, certainly, and whenever we're able to. One of the big challenges, though, of course, is that for peripheral pulmonary lesion localization, there's really no clear guidelines in terms of what nodules to localize and what not to. There's some suggestions on size and characteristics, subsolid or ground glass, distance from the pleura, etc. But there really isn't any consensus guidelines out there yet that says, this would be the kind of expert opinion recommendation. So definitely a portion of the literature that needs some time for maturity and some time for guidance. But when we think about this whole process, one of the big drivers now that is changing the way our field is practicing are these two incredibly important papers that came out in NEJM and Lancet Respiratory Medicine, looking at lobar versus sublobar or segmentectomy for early stage 1A cancers, non-small cell lung cancers. Similar designs for both of these studies, looking at similar types of patients, early stage lung cancer, less than 2 centimeters in size, T1A and 0. And you can see that, in both groups, almost 700 in one study and over 1,100 in the other. When we look at the follow-up time for at least 7 years, what they found was that sublobar resection was either not inferior or segmentectomy was superior than going forward with lobectomy. And similar, 5-year disease-free and relapse-free survival was seen. So this is a really big changing in our kind of practice, where if we previously had found the nodule, we said, well, we're going to remove this surgically, and that's going to be a lobectomy, and then we're going to move forward with the patient's care and follow-up, etc. But now there's more and more evidence to support changing the way that we're practicing, and it's becoming more and more clear that really when we want to remove something surgically, we want to try to do that in the most minimally impactful and lung-sparing approach as we can. And bronchoscopy with marking of these lesions really has a tremendous potential to impact that process moving forward. The other thing to talk about with bronchoscopy is not only nodule localization, but also treatment. So this is a great paper by Dr. Cooley in 1893. So we're talking 130 years ago. And it actually talks about using intratumoral therapy for treating cancer. He had a series of sarcoma patients with visible lesions, and he would inject them with live cultures of Streptococcus pyogenes. And what he saw was the regression of the sarcoma lesions visibly that he could see and he could measure after he was injecting these live cultures directly into the tumors. So this is really the first example of cancer immunotherapy, and this is 130 years ago. So this idea that we can directly impact cancer and tumors at the site of the malignancy is something that's been around for a long time, and it's something that over the years we've realized a lot of different ways that we could potentially do this from a bronchoscopic standpoint. The idea would be that if you injected something through bronchoscopy, you treat not only the tumor, but also the nearby microenvironment. And as you can imagine, if you're treating something directly with a highly potent agent, you can potentially increase how long it's going to stay there. so it has a longer duration, and then you can use a smaller amount that isn't going systemically, or at least not traveling as dramatically through the body systemically to decrease toxicity. So some really impactful things that can be done potentially in the therapeutic range for what we can offer bronchoscopically. So when we think about therapeutic readiness, one of the big things that we need to be confident in is that we can really see the lesion in real time. And if we can do that with something like ILLUMISITE, where we do the local registration and we know where the tumor is in real time, that's an incredibly impactful and confident part of the procedure, that we know we've identified the lesion correctly. And it can allow us to obtain the diagnosis. It allows us to, like we were talking about, is mark the location successfully to help facilitate a lung-sparing surgery or radiation therapy. And then it has the potential to help facilitate delivering ablative therapy in the future. So all really impactful things that can be accomplished with the bronchoscopic navigation system. So when we think about the ILLUMISITE platform, kind of summing things up here as we head to the end of our conversation, one of the things that is really impactful is that local registration and fluoroscopic guidance, it corrects for that CT biodivergence. You can see where the lesion is in real time while you're doing the navigation bronchoscopy. And that's incredibly impactful to know that you have the lesion localized and then can make the minor manipulations to help successfully biopsy the lesion or place markers around it. Additionally, it has the ability for you to get some real-time feedback, so you know what your biopsy tool is doing in relationship to the lesion. You know what adjustments you can make and need to make in order to get that confirmation of diagnosis for your patient. As we talked about, some of the initial studies have shown some promising improvement in our diagnostic yield compared to prior meta-analyses and registry studies. And like we were talking about, if you can feel confident that you know where the lesion is in real time and how your tools are interacting with it, this can help to facilitate things like either a lung-sparing surgery or eventually local ablative therapies in the future. And so with that, I'll say thank you and take the opportunity to answer any questions if there are any. So thank you very much.
Thank you so much, Dr. Ben, for a very informative presentation. Monica is going to hop on and we're going to go over some questions. As a reminder to the audience, please feel free to use your question feature on your control panel. You can submit them and then we will go over them. Thank you.
Yeah. Thank you so much, Dr. Ben. We do have a few questions here. So in your paper about cryobiopsy, what do you think it was about the addition of the cryobiopsy that improved the diagnostic yield?
Yeah, it's a great question. It's something that it's hard to say conclusively because of the small sample size that I referenced. But what I would say is the biggest improvement in diagnostic yield, I think, came from architecture. I think that by having histology that was not crushed, we had our pathology colleagues feeling more confident that they could give us some diagnoses of non-malignant disease processes. So like your organizing pneumonia, inflammatory processes. I think that's really, really helpful because there really isn't a challenge or question about is this malignant when we see cancer cells, right? That really is never the question. If we find cancer cells, it's 100% specific, right? We believe that it's real, it's truly malignancy. The challenge is if we find non-malignancy, do we believe that we really sampled the lesion accurately? Did we miss it nearby? Did we get just the periphery or the edge of the lesion? So to that end, I think, getting architecture, knowing that we could sample it in multiple different orientations and kind of relationships using the continuous tip tracking, I think getting some really good pieces of tissue that showed architecture gave us confidence that this was a non-malignant result.
Great, thank you so much. We have another question here about fiducial markers this time. What type of collaboration or conversation do you have with RADONC when you're placing fiducial markers?
Yeah, it really depends on the situation. So it can go in both directions. Many times the patients are coming from radiation oncology for a specific, can you please place markers in and around this lesion? We're going to facilitate SBRT. Please do that. Other times it's, hey, I think this patient is going to be needing radiation oncology because I see the PFTs, I see the radiographic emphysema, I see the performance status. Can you please tell me if you think this patient would be a good candidate? So I think it's a bidirectional conversation. And then one of the things that is, I think, really important in terms of not only the workflow, but when you're actually doing the procedure, is to talk to your colleagues and find out, what do they need? Do they need one marker? Do they need two? Do they need three? Are they using bone or other anatomical landmarks that are stationary to help guide their, their treatment field and their treatment plan? Are there certain markers that are better in terms of compatibility with their radiation equipment? So there's some good conversations to have to set some good parameters and kind of ground rules for discussion. But I think it's great to have just a nice flow back and forth and kind of a good conversation with your colleagues.
Great. And that kind of leads into the next question. So how do you assess whether, a fiducial has been placed accurately?
Yeah, so that's something that we were talking about during the conversation, right? One is to say, okay, did the patient wake up from the anesthesia and there wasn't a pneumothorax? Okay, success, that looks great. But another metric, I think that's a little bit more objective. The latter there, obviously, the former rather is a little bit more subjective, but another option is to really think about the imaging. A lot of these patients may get a CT scan prior to their thoracic surgery because they're going to want to have really up-to-date, accurate information for when they're doing their planning for their thoracic surgery approach. So you can go back and look to see if it's placed in and around the lesion. That's a nice metric to use. And then another, of course, is you'll see some radiation software planning for the patients for their SBRT. And so you may want to ask your colleague and say, hey, how did I do? Did this really help? Or did I kind of miss the mark on one or more of these? I think those are some of the objective measures that I think are much more important to really focus on rather than just saying, yeah, it looks good to me on a portable x-ray while the patient's waking up from anesthesia.
Perfect, thank you. And I think you've touched on this question a little bit, but does the type of SBRT being used influence how and where you place your fiducial markers?
It can, yes. I think that's one of those conversations you really want to sit down with your radiation oncology colleagues and just say, what can I do to help facilitate this process? What do you need? Is there a certain type of location? Is there a certain type of number of lesions, or sorry, number of markers? Is there a certain way you want these things placed, and how can I best help? So yeah, there are things, but I think it's unique probably to each situation, and you want to talk to your colleagues about that for sure. Okay,
great. Thank you. I think that is all of the questions we have for tonight, unless there's anything else. So thank you again, Dr. Benn. Excellent, presentation, and I think I'll hand things back over to Emily then, if that works.
Yes, thank you so much, Dr. Benn, for the great presentation. And thank you once again, Medtronic, for sponsoring SAB this year. I do have a few reminders as we do have an upcoming webinar this Thursday with Dr. Shostak. If you all can join, it will be an excellent presentation as well. And the SAB will be in Honolulu, so we look forward to seeing you all there. And we will be having a booth at our first CHEST event. And we look forward to seeing you all at future events. Thank you. Have a wonderful evening.